All right, this is our chance to capture at least a good part of the wisdom of the discussion, and we'll do that by hearing from each of the leaders at the tables. Before I do, Alina asked me to make a request of you. For each of you who are moderating these and are going to be speaking, if you could send Alina an email tonight with sort of high-level thoughts about what you heard at your table. She has the detailed comments, but she would welcome sort of a few sentences with a high-level description of what you heard, what you learned. So we have about an hour to hear and capture at least some of the thoughts that came from the table. So the plan here is for each of the moderators to provide one or two main themes or ideas that they heard at their table. And obviously that's not going to capture the richness of all of this. And so we'll go around from table to table. Ultimately, Alina and colleagues will be summarizing things from all of the notes that you took. So we hopefully won't lose all the thoughts that won't be discussed here. So let's start. And table one was none other than Alina and Baciu. So please, Alina. I think you told me to tell people to do it from their tables, but however you like to do it.
I'll bring it around. Okay, so this is the reporting back from my 4 rounds of conversations, and I have 3 high-level points I will share. One was that we need new or novel methods to collect data to complement non-real-time data that we have from the various surveys. And the idea was to involve kids and neighborhood members and perhaps getting middle schoolers to deal with the food environment and getting high school students to provide other kinds of data, help with other kinds of data collection. A second idea that was shared was that language and communication are super important in how we talk to the community in data collection, and that sometimes data collection tools fall flat because they are asking the wrong questions for that particular ethnic or racial group, or they are asking them in a language that people don't understand, either literally or figuratively. And finally, it's hard to align data with action when the evidence is thin, and we need more intersectoral social determinants of health, hybrid sorts of research, but there's not enough support for that from the government and other sources.
Thank you, Alina. So what we're going to do is we're going to go around and hear from each of the tables, and then if we have time at the end, we'll look for other comments. So, Amy?
Hi. So we talked about a lot of different things, but one of the common themes I saw was around funding. So one thing is we need granular data, but often the only way right now to get that is you have to pay for it. So it's either proprietary or you have to do oversampling. However, first you have to decide, you have to talk to the community, decide, what's the problem and what data do they need. And often you need funding to be able to even get to that step. And then also you need sustained efforts. And often in public health, we all know that there'll be some funding and then it will go away and then you can't keep going, so if you were collecting data in an area, then you can't keep doing it, and then you can't circle back to that community and tell them, anything, often the data then doesn't get back to them, or they aren't able to learn from it, or they aren't given the tools to take action on it. And so, maybe only the funding was given to collect it. And so, without the sustained effort, we can't make progress. We need to go where the money is, and so often, hospitals or clinical care, community health benefit, and so get them on board with meaningful measures and ways to kind of triangulate and combine data and how to use that data then in an actionable way, like what is relevant to folks in clinical care, along with public health. It's something we've all been, I think, talking about for years and is still important. And also, from another angle, it would be useful to have data on investment metrics and metrics to benchmark against other communities. For example, what would it cost to scale up and to leverage funds? And then sorry, I can't even read my own handwriting. I'm sorry. Oh, and so because there isn't always funding available, you know, we need to accept that we're not going to always have the perfect measure. And, you know, a lot of us are always looking for that perfect measure and making sure it's just right, but we can't always have that. And we need to not let that stop us or communities from taking action, and need to also find more innovative ways to get data or different innovative data sources like social media. And then finally, politics can get in the way, certainly, of funding streams, and you know, compelling data doesn't always make change. And so we need to think of other ways to either frame the data better in a, you know, a way that perhaps they could use it, or find ways to work around it. And oh, and finally, one of the last things that was said was finding examples of how measures were used successfully and being able to share those with people to sort of get over this apathy of how are we going to change things, or this is just how things are, so we're not going to be able to change it, but to be able to show perhaps not the outcomes yet, because pop health outcomes take a long time, but to say, well, these measures actually informed this policy or these decisions or things that were done. So that's it.
Thanks, Amy. And Mary Lou Goeke?
Our groups talked about helpful measures that they had experienced were those that had purpose and relevance to the daily lives of the people involved, that the people had been involved in selecting them, and that they believed they could actually make a change. And they also talked about helpful measures that are hard to find but important, like measuring isolation, social support, connectedness, and things like that. Some of the barriers they talked about had to do with the difficulty of turning metrics or measures into convincing stories that people could use for change, and also that a barrier is lack of trust that might actually be well placed in the source, in the accuracy and the motivation of the group presenting the data, or even the ideology of the people presenting the data for action.
Can you pass it to Martha over here? Martha Gold?
So many ideas. Helpful measures would be, from the community perspective, resonant, fit the context and the pressing needs of the community, and certainly actionable. They need to be practical and easy to measure and inexpensive to measure. They should be understandable by members of the community so that they can be both motivational and aspirational, and importantly, empowering. They should show economic potential, because health alone doesn't always get people up in the morning. And they should be able to serve different kinds of narratives, so they should be different contexts that they can be used in to tell a story. Barriers that people cited were institutional resistance to measurement. Often institutions want to do what they've always done, and measurement may provoke defensiveness. Big measures may not be sufficiently relevant or flexible for what is needed. So by big measures, I mean the validated measure sets that are being promulgated. There can be a lack of buy-in from the community, concerns about the sensitivity of the questions that are raised, the notion of being burnt by lack of accountability previously, with the same questions being answered over and over again and not relevant to the problem. Lack of resources is clearly a common theme, and I think those are the top level thoughts.
Pass that on over to Lyla. Thanks, Lyla. Hernandez?
Our groups thought that the kinds of measures that would be helpful to communities are social, environmental, and demographic data at the local or neighborhood level. They would like measures of social capital, connectivity, and engagement. They'd also like to have measures that show what kinds of resources are available for use, and measures that are easy to understand and important to the community. They think that linkable data, education to health, to criminal justice system, to transportation, to et cetera, is very important. They think workforce data for health, social work, other kinds of professions is important. For example, does the workforce in that community that is, quote, helping reflect and come from the population they serve? And if not, how does that affect the ability to function? And also there was a strong feeling that qualitative data were needed to help inform the quantitative data, similar to several things we heard today. In terms of barriers, major challenge is defining the measures and obtaining the data, having resources to collect, analyze data, and then take action. It was pointed out that sometimes one runs into ideological barriers, so that no matter what kinds of data you present, those data are rejected as being an accurate picture of the community because it doesn't fit with the ideology of the group to whom you're presenting the data. Also, there seems to be some concern. It kind of goes along with the ideological issue of blaming the victim. Trying to combat the idea that health outcomes are inevitable. That is, my mother had diabetes, my father had diabetes, my grandmother had diabetes, so I'm going to have diabetes. Overcoming the idea that some think that only the data that are collected by the community in the community are relevant and useful. No outsiders allowed. There's too great a focus on return on investment rather than identifying other values. Major problem was perceived as when one is trying to gather stakeholders together to take action, there's a lack among the stakeholders of collective vision and perception of what is currently and what should be. For social determinants of health, we talk about holding people accountable for change or for the current situation, but who's accountable for those kinds of determinants, and how are we going to hold them accountable? And then that there is a lack of linkage between upstream and downstream indicators, which makes it difficult to decide where do you intervene and in what ways.
Steve?
Okay, we had some very robust discussions with regard to helpful measures. One of the things that came up several times was this idea of sort of capacity, measuring the capacity of a community. I think inherent to that capacity term were things like political will, the extent of cross-sector interaction already existing within the community, the availability of leadership, sort of on-the-ground providers, and then the willingness of the community to engage. We also identified measures that would be helpful were those that sort of break through stereotypes or assumptions that are made by people in the community. Measures that also have short cycles. In other words, we can get the data quickly, and maybe more importantly, we actually do something with that data quickly, as opposed to sticking to more common academic cycles where it takes a long time for data to actually be published and actionable. We also discussed getting metrics that were cross-cutting, that linked sectors. And we had a couple of interesting ones which I thought were outside of the box, talking about measuring the extent of community engagement in developing the metrics, and measuring the extent to which the community understands how their data are actually being used to inform change. As far as barriers went, we had some discussion around this idea of excess measurement that's coupled with a lack of action, or even when action does take place, a lack of communication to sort of close that loop, which I think erodes trust within the community. And we also talked quite a bit about inadequate marketing being a barrier. So, you know, even when we have ideas of what needs to be done, being able to get people to buy into that, to sort of internalize that data, that's a challenge. I think most of the other ones were sort of covered by the other groups.
Great, thanks, Steve. And if we can pass that to Brenda Sullick over here.
Thank you. A lot of the points that we came up with were already mentioned, but in terms of helpfulness, we thought what we heard this morning was very important of always remember purpose before measure. We also thought that it's important to look at, it'd be helpful for to look at the community first. The measures need to be meaningful to the community, accessible and tangible, so they can see results. Sometimes we start with the research and don't think about the community till later. Look at the community level for your measures, not just individuals and making people feel guilty. Measures should be representative of the community, need for narrative stories that they can relate to. And that's the other two are more barriers, but I have them on my helpful list. Barriers, again, making meaningful measures for different audiences. They need to be understood by the community. Data sets need to be linked, maybe a type of clearinghouse or a cheat sheet of what's actually out there now and what's working and how they can be used instead of recreating all the time. Also, a barrier is that stakeholders don't always see the value of metrics, so it's involved to make sure up front that all the people that are going to be in a position to make a decision about this understand what is being measured, and the measure should be more appealing in terms of making them personalized to folks, offering incentives. The example that was used was Zillow cuts their data by neighborhood and walkability in schools, and so people like using that because it means something to them. And then to make data linked to the family, this isn't a barrier, but it should, what we'd like to see, make data linked to the family as more of a health unit. So for example, it's a good rule, and you're doing it for your kids, not just the outside.
And the next one is Kate Papa. Long arms, thanks.
Okay, I'm trying to see what's new here.
Well, redundancy's okay.
Okay, so I think there were five kind of themes that came up at table 8. The first was politics. Politics can drive and block action. You need political will. Number 2, and this came up with Alina, Marthe, and Steve, was framing that you need, but my group talked a lot about being asset-driven and talking about motivating and positive aspects of the community and the ways that the data can move health in a positive direction. And also using communication to drive public support. So related to public support, we talked a lot about community will, collective impact, making sure that there's a common agenda, that you can kind of create a rallying call around something sexy, perhaps. Number 4 was related to what Steve was talking about, I think around capacity, was that we don't know what to do. So this came up in 2 different ways. One is we don't have any epidemiologists here to do anything with this stuff. And the other is we don't know how to use these data. We don't know what policy and systems change these data can be used to drive. And then lastly was a lot of discussion about data quality, poor data, data being thought up by someone who didn't know that data already existed. And then we came up with a fascinating new idea for a TV show on data hoarding. We don't know how many epidemiologists actually have a television, so we're thinking that the audience, there might not be enough viewers for that. That's it.
Wow, that is the ultimate. All right, Darla.
Data
Thompson.
hoarding.
Oh, that's hard to follow. So in terms of what kinds of measures are helpful, I think that the first round, it actually turned into more of a question of how can we create measures that actually capture the complexity of people's lived experiences? And the other round, the big question really was, how do you measure cultural sensitivities? And this was actually linked to Alina's comment about language, is like what kind of language is used in the actual design of the survey. at what level are you incorporating understanding and awareness of the community in the design and execution of the survey? In terms of barriers, so I think both of those are actually linked to the barriers. And similar to what I heard from a lot of others, getting data that is granular enough that people think it is actually applicable to their community. Are we collecting the right information and data? Issues of competing interests and competing motivations when you're working in a multi-sector environment. And then it becomes the issue of who will actually take action. When it's time to take action, who is actually going to do it? Again, issues of trust in data. There's no collective ownership over the data. Again, I think this tends to be when it's multi-sector. We don't have good measures for social impact. A lot of data is in different formats, and so that can be a challenge to actually bring it all together. The challenges of getting the data to the right people, the challenges of politics, but also the challenges of connecting data to the stories, which again, I think resonates with what a lot of others said. And again, this applies to different audiences, right? Is that if you want to be able to package the data and link it to stories that are compelling to very different audiences. So just the time and resources it takes to do that. So I'll stop there.
Grab that. We're going to go back over here to Matthew Trowbridge. Matthew, you're on.
All right. Well, like everybody, our table, I think a lot of the same themes were echoed. So I'll try to focus on some things that I really took away. I think it's a testament to the speakers we had this morning that we were all really inspired by a lot of the things that were going on, including things like watching Robert Wood Johnson try to really fundamentally change the way they're taking on change. And so what I think I took away from watching these conversations was that we really actually should own and just recognize that we are really at a fundamental moment of change in terms of how we in public health are really trying to switch from measuring purely outcomes in a more traditional way and really moving towards, we're all it's so embedded in this conversation, which I think we should take a moment and realize we're now really focusing on social and environmental determinants and trying to measure those and have those be, in some ways, the outcome measures of our projects. And that's a really fundamental change. And when you think about it that way, a lot of what I picked up on in terms of barriers are that there is a tension right now between that goal and the existing infrastructure, whether it's at the health department level. We heard, folks saying, hey, I get a mandate to go after social determinants, but very quickly the types of things I'm supposed to be focusing on go outside of my mandate within a very traditional bureaucratic structure. Similarly, funding cycles. NIH grants and things like that, at the maximum, you're going to get to do a 4-year type of grant. Someone actually said, 20-year commitment by Robert Wood Johnson to a culture of change. If you really think about it, it's actually a fairly short period of time for the types of change that we're talking about. And I think that that's important to just recognize that that is a barrier right now. Like, we're at a moment where the way we get research done, the way we actually do things at a department and health level, it's not quite set up to do this type of work yet. So we've got some work ahead of us there. I personally thought the conversation within the equity conversation, but the idea of making sure that we are our measures going towards the average all the time, and hence not really doing a very good job of illustrating anybody's particular point. And when you think about, and so that's generated an interesting conversation at our table about perhaps our measures should actually really go after the outliers more than the average in terms of, and then bringing up the idea of things like in the built environment world, if you plan a community to serve a 8-year-old and an 80-year-old, turns out everybody actually enjoys that community a lot too. Maybe the way we deliver healthcare and target change should do the same thing. If we instead flip the idea of these are 5% of the people are using all of our resources, maybe it's like, perhaps if we designed our healthcare delivery to serve those 5% optimally, I think everybody would enjoy that system as well. So fundamental moment of change, I guess, is my main theme.
Great. Thanks, Matt. All right, Julie.
Well, wow. there was a lot that was said at table 11 and similar to many of your tables too. I was struck by a theme that emerged at this table and that I'm hearing in other tables too, is the centrality of the community voice and thinking about measures. And I'm struck, Matthew, too, by how different that is than if this conversation had happened 5 years ago or 10 years ago. So in terms of what to measure, there was a lot of discussion about assuring community relevance, that the community has heard some of the same themes around language and cultural sensitivity, and also then how we wrap those measures up to really be reflective of the motivation and inspiration of the collective and of individuals. I think that theme about the humanity of these measures resonated at our table. Again, another interesting point about measures was whether you start with measures or you start with priorities or how you merge that. And so we had some really rich conversation about, you know, looking at measures and deciding what's important or deciding what's important and then using measures to better understand the issue. Barriers, we flipped into actionable items at our table. And so we talked a lot about the concepts of trust, and that trust, if we're going to do this in a multi-sector fashion, we have to build trust with other sectors, with other people, how we build common ownership, how we build common stewardship around those issues. And then the realities of resources, which I know others have spoken to about this, the cost of data, the sustainability that so much of this work gets dependent on grants or resources that come and go, the opportunity to do much better cost-benefit analyses and have that inform our work, and much better research on what are the most effective strategies to make these changes. So.
Super, thanks, Julie. Yeah. You can pass that over to Kelly. I'm sure we've saved the best for last, right?
I mean, I hope so. I'll try. I'll try not to repeat too much. So I think what was really interesting is we had some common themes pop up from the first conversation about what sorts of metrics do you need, that flipped over to the barriers as well. So I'll kind of bounce back and forth. One of the common themes that's been touched on, Darla spoke about this, is just the need for human-centric and patient-oriented measures. But one of the comments from my first session that really stuck with me was the idea of functional versus clinical measures, in the sense that a patient is going to say, I don't want to go to dialysis. The patient's not going to talk specifically about their HbA1c levels. So just thinking about the framing of the measures as we're interacting with patients. And then also the level of data collection versus the level of action. You know, we all recognize a need for interdisciplinary measures and interdisciplinary work, but then we confront a barrier that's associated with the lack of communication between different sectors. So many times you have a situation where on the public health side, we're collecting data at a level that's not quite actionable by the system that we're trying to push, that's not the system that we own. And then I think also, you know, conversations about presenting the problem in an actionable way. One thing that I really liked about the work coming out of San Diego was the idea of creating measures that you can talk with both the scientists and the neighbor, and that both kind of get what you're saying and are going to go a different way with it, but being able to present the problem in a way that is actionable. So I think that covers it.
Thanks, Kelly.